Okay. Everyone see me and hear me okay? I hope so. Good afternoon and good evening for anyone who is joining us on the East Coast. And welcome to our Revive and Thrive Finding You in Lupus virtual symposium presented by More Than Lupus. My name is Kelly Rosetta and I am a 29-year lupus thriver and the creator and executive director of the Portland-based nonprofit More Than Lupus. Today's extraordinary event will feature lupus experts and lupus advocates sharing their insights on not just surviving lupus, but thriving with it. And as we delve into this subject, we encourage you to be open and patient with yourself wherever you may be in your lupus journey. We have no doubt that many of the things that you will hear today will change your perspective and hopefully set you up for success, whether you are living with lupus or another lupus overlap disease. Now, we encourage you to stay with us for the full hour because we will have a prize giveaway at the end and you don't want to miss out on the opportunity to win. So without further delay, it is my pleasure to introduce our host/moderator for today's event, Mrs. Molly McCabe. Ms. Molly McCabe is an experienced entrepreneur. She's a leader and board member in the nonprofit arena. She co-founded Molly's Fund Fighting Lupus with her mother after being diagnosed with lupus in 2005. During her time with Molly's Fund, she developed support groups, patient programs, and advocacy efforts that led the way for many other patient-driven nonprofits to follow, including More Than Lupus. Molly spearheaded a critical partnership between Molly's Fund and the ALR, now known as the Lupus Research Alliance, the world's largest private funder of lupus research. Molly currently serves on the board of directors for the Lupus Research Alliance, where she was honored last year for her involvement with helping to create and implement the PALS program to enhance patient engagement in clinical trials. Please welcome my friend and staunch lupus advocate, Ms. Molly McCabe.
Hi, everybody. I'm so glad to be here today to share with you and to enjoy this wonderful experience. As Kelly said, I have been a lupus warrior for the past 15 years. I was diagnosed at the age of 27, and I was an opera singer at the time. I had a major contract coming up and I lost it, and I pretty much lost my career at that point because I was so sick I couldn't perform anymore. I went into a downward spiral after being diagnosed for about a year and tried to figure out what I could do with my life now that I didn't have as much of a purpose as before. And finally, my mom and I started talking about starting something to help people in my position. We invited our closest friends and family over and created Molly's Fund Fighting Lupus, where I served for 10 years. And now I'm proudly serving on the board of the Lupus Research Alliance. Before I introduce our special guest today, I want to read a brief disclaimer for those who are joining us live and those who will be streaming this later on Facebook and YouTube. Please understand that the opinions shared today are purely for informational purposes and do not replace the medical advice and/or opinions of your doctors. If you are experiencing lupus or lupus overlap symptoms, it is important to follow up with your doctor and to seek the treatment that is best for you. Dr. Thomas is a qualified medical professional whose comments are based on years in the medical field. However, he is not liable for his comments since he is not acting as your personal medical provider and does not know the nuances of your medical history. And now for a little bit of background about Dr. Thomas. Dr. Thomas is a rheumatologist who has specialized in the treatment of lupus for over 25 years. He has served as an assistant professor of medicine at the Walter Reed National Military Medical Center, as chair of the Medical and Scientific Advisory Council for the Lupus Foundation of America, chair-elect of the National Board of the Sjogren's Foundation, and as a research consultant for the National Institute of Health. Dr. Thomas is mainly known in the lupus patient realm for writing the best-selling patient lupus handbook, the Lupus Encyclopedia, which due to its popularity will soon have a second edition. Having treated over 200 patients in his career, patients love Dr. Thomas for his investment into their well-being and accessible manner. Please join me in welcoming Dr. Donald Thomas Jr. Dr. Thomas?
Yeah, thank you. Yesterday I got a phone call that I dreaded. And this is one of the things about being a physician that we don't like to get. I got a phone call from the University of Maryland Stroke Unit, and they wanted to talk to me about one of my patients that they had to admit on Thursday night. She's a patient of mine who I've been following for a few years, and she has something called antiphospholipid syndrome. Antiphospholipid antibodies are antibodies that about 30% of lupus patients will have, and about 50% of patients who have them will get blood clots. Some people call it sticky blood syndrome because it makes the blood thicker than usual and it can cause clotting in the arteries. Anyways, she has been on Plaquinol or hydroxychloroquine, as well as a blood thinner called warfarin, because she had had a stroke when she was in her 20s. And then just this year, earlier this year, she had some mini strokes, or what we call TIAs. And so the first thing I asked them is what was her Coumadin drug level, the PTINR? And it was 0. And that just broke my heart. She's a PhD, incredibly smart lady, just bubbly personality, one of those people I just love seeing in the clinic. And unfortunately now she's laying in a bed in the hospital at the University of Maryland. It attacked the part of her brain called the cerebellum. And now her eyes won't focus. She sees double. She's not able to stand and walk because she's too unsteady. Her hands and arms aren't able to keep steady whatsoever. And who knows what her future is going to be at this point. So this brings up a really important topic to me, and that's called the Lupus Secrets. And anyone who's read my book or been to my website or been to the Facebook page, you've seen me talk about the Lupus Secrets many times. And these are really, really important things, because I know from many years of experience that patients who follow them do so much better in the long run than patients who don't. They're just not things to look at and say, oh, that's a good idea to do that. It's things that I know if people do every single one of them, they're going to do so much better in the long run. And one of those Lupus Secrets is, please take your medicines religiously and don't miss any doses. And there's a reason for that, is that the #1 cause of patients flaring up with their lupus is not taking the medications regularly. And it's such an important thing. One thing you may think about is that doctors don't make very good patients. Well, I have to say that's not true. Every single morning, this is what I take. And yeah, I suffer from my own chronic illnesses myself. And a lot of times I'll have a patient say, well, I'm tired of taking medicines. I have to take so many pills every morning. Well, I tell you what, that's a lot of pills. And guess what I tell myself every morning? Thank God that we have modern medicine, so I'm able to live a lot longer and have a much better quality of life than my parents, my grandparents, and my great-grandparents. I know that if I don't take my medicines regularly, that I'm at high risk of a stroke or a heart attack. Personally, I want to live a long time and have a great quality of life. And so that's it's always good to have a way to have an internal dialogue in your mind as far as getting over these types of humps. And unfortunately, my patient, who's the PhD, she did something that kept her from taking her medicines. And of course, we'll explore that issue when she comes back in for her next appointment, which I hope she recovers from this stroke well, so we can get rid of those obstacles that she had. But for example, my medicines, I take them twice a day as a maximum. That's not very much. I know it should be easy to remember twice a day, but even as a doctor, I kept forgetting that second dose. And so I had to figure out a way to remind myself to do it. So I subscribed to something called Pillpack. And many of you might have heard of Pillpack. They put your medicines in these little packs like this, and they've had the date and time on it. And like tomorrow morning, if I got up and I noticed that it said 8 p.m. from tonight, and go, oh, I forgot my medicine last night. And I know I can take this in the morning, and they kind of spread out my medicines for tomorrow. So it's really important to figure out how to come up with ways to overcome obstacles that are keeping you from taking your medications, for example. I'm really happy that Kelly and Molly are having this discussion this afternoon. I was going to talk for about 30 minutes about my Lupus Secrets, but we decided to have more of a discussion with questions and answers, because this is really about you, the people with lupus who are watching this. I'd rather have it more about you participating and helping out. But before we go to the question and answer session, I'd just like to mention a couple of my favorite Lupus Secrets. Some of the most important ones. Number 2, if you are on hydroxychloroquine or Plaquinol, please take it religiously. Hydroxychloroquine, also known as Plaquinol, is the only drug proven to prolong survival in lupus. It's the only drug proven to extend survival in lupus, and that's so important to remember. It seems like such a weak medicine, but it has so many positive benefits. It's just phenomenal. And by the way, I think that Benlysta is going to be shown to do the same thing in the next few years, because the studies behind Benlysta are just crazy good. Number 3 is use sunscreen religiously, even if you don't go outside. And the reason for that is that one of the things that makes lupus active is ultraviolet light when it contacts the skin, even from indoors, unless you're using LED lamps, because LED doesn't have UV light, but incandescent light bulbs and fluorescent light bulbs have UV light that's constantly bombarding our skin, and then it damages the cells right underneath the skin. And in fact, that's why we wrinkle, is because of that damage. But in lupus patients, this is really bad, because the cells, they release their contents into the bloodstream, and that includes the nucleus and the proteins in the nucleus. And remember, you have that anti-nuclear antibody. You have anti-nuclear antibodies that seize those proteins from the nucleus. And so your immune system sees that and becomes more active and starts to attack it. And then it makes these immune complexes that float around through the bloodstream. It can go to the kidneys, the joints, and cause inflammation and damage there. So wearing sunscreen religiously every day, even if you don't go outside, is so important. There's a long list of other things you can do to help decrease ultraviolet light contact with your skin. And that's just as important as hydroxychloroquine as one of your medicines. In fact, I actually put sunscreen on my patient's medication list, because it's such an important thing. And then before we go to the Q&A session, I'd like to just tell you one more story about another patient, just real quick. This one has a happy ending, so a little bit different. But one of my patients, she follows my Lupus Secrets religiously. And just this past year, she had a flare-up. She had a flare-up of arthritis. Her skin lupus became active. She had horrible fatigue. And I was really surprised, why does she have this flare-up? And one thing I've been doing the last 3 years is I've been checking hydroxychloroquine or Plaquinol drug levels on all my patients. Number 1, to catch those patients who are being poorly adherent to their treatment, which ends up being a lot. And now that they know I'm checking it, they're really good at taking it. Number 2, though, is to make sure I had them on the right dose, make sure their dose is not too low or too high. Anyways, I checked her level, and it was very low. And so I asked her, I said, Mary, why are you not taking your medicine regularly? And she said, well, Dr. Thomas, when I got my medicine this past year, the pharmacist put on there that I had to take it with food. And they said, well, Mary, I'm glad you told me that, because you don't actually have to take it with food. You can take it on an empty stomach most people tolerate it better with food, but you don't have to. And in addition, you can take both tablets at the same time once a day. You don't have to spread it up to one at a time twice a day. And so we were able to find her barrier to what was keeping her from taking her medicine regularly. She started taking it religiously again, and she is in complete remission again, which I'm happy to report. But what's even better is I got this wonderful thank you card. It's really neat being a doctor. I wish everybody had a job as good as mine where you love going to work every day. I mean, how many people get this kind of thing, you know, from at work? But anyways, this is what she put in the card. It says, "Dr. Thomas, I highly respect you as my doctor. I thought I really had to take my medicine with food, and I would put it aside until I have eaten, and I would keep forgetting doses. This has truly been a wake-up call for me, and I really enjoy having you as my doctor. You really care about your patients. God has kept me here with your help, and I want to live a long time." And by the way, I'll just preface it that she has a lot of lupus in her family. A lot of relatives have lupus, really severe lupus. And she says, no one in my family has lived past the age of 60 years old in my family. The cool thing is she's 73 years old. 73 years old. Today's treatments are so much better than we've ever had in the past, but you have to do your part on doing the right things, and she absolutely does. And then she just sent me another thank you card. I just have to read something really quick from this one because it was really cool as well. But she says, "My youngest granddaughter was 6 months when I was diagnosed with lupus. She will be 30 years old on November the 10th. That's 3 days from now. I have only thanked God and you for the last 29 years of my lupus survival." And by the way, it's not me that should be congratulated. It's her, because she's doing the hard work. And so I hope that everybody does really truly go by my Lupus Secrets, because I guarantee that you'll do much better with your lupus compared to than if you don't. And for the rest of the time, I would just like to answer any questions that people have, because you're the important reason we're here.
Well, I'm glad to hear that, because we have lots of questions for you, Dr. Thomas.
Great.
Let's start off with this one. I have heard that lupus is most likely caused by a combination of genetic predispositions and epigenetics. Do you think that a person could develop lupus if they don't have the genetic variants linked to this disease?
That's a good question. We really don't know. That's really the realistic answer to that question. And the reason for that is that we don't know all the genes that predispose people to have lupus. When I first wrote the first edition of my book, there was approximately 50 genes that were identified that predispose someone to having lupus, but now we're close to 150. And so if we would have done research studies just a few years ago looking for genetics in people with lupus, we would have missed those patients who, had these other genes that were just recently identified. So that's an evolving story. But theoretically, I think that you probably do have to have the genetics to end up having the disease. So for people who don't understand the genetics part of it, lupus is a genetic disorder. You probably do need to have the genes to predispose you to the disease. The more genes you inherit, the more likely it is to develop lupus. In addition, not all genes are created equally. Some of them are super genes. Like you can get one really bad gene and probably get lupus because it's so strongly associated with lupus. And there can be another person who might get 20 genes that are associated with lupus, but they're very weak genes and never develop lupus whatsoever. But it also takes something to trigger these genes on and turn them on. And this person who asked the question, I could tell they're really smart and have done some reading. They included the word epigenetics. So genetics refers to the actual DNA and RNA, the code that tells us who we're going to be, why we get blue eyes versus brown and white skin versus black skin, etc. But epigenetics epi refers to what's around the genes. And so you can have this one particular, and a good example for lupus, by the way, is most of these genes are actually normal genes of the immune system that just work differently than usual. And there's, for example, there's one type of gene that increases the production of something called interferon. When you get a viral infection like the flu, one of the ways that we combat the flu is through making something in the immune system called interferon. These are molecules that help us learn to attack the virus and protect our own body. There are people with lupus who have overactive interferon genes, and when those are active, they make way too much interferon that ends up attacking the body. And in fact, one of the medicines that may become FDA approved in the next year actually is an interferon inhibitor, and I suspect it may very well become FDA approved. Cross our fingers. But that interferon gene, that super gene, it sits there and it's dormant, it's quiet, but if something occurs around it in the DNA that can turn it on or trigger it on, then that person can get lupus. Some of those triggers include things like cigarette smoking, ultraviolet light contact, low vitamin D levels, stress. Stress has absolutely been associated with triggering lupus. And even the lack of sleep. There was a study that showed that people with less than 7 hours of sleep a day are more prone to getting systemic lupus in families that have lupus compared to people who get more than 8 hours of sleep. Another lupus secret, you need to get 8 hours of sleep every night. So that's the epigenetics part, is it does take something to trigger those genes and turn them on. So sorry it's such a long answer to a short question, but I hope that helps.
It did quite a bit. Thank you so much. Question number 2, my doctor wants me to try Benlysta. However, after reading the side effects, I am nervous because I've read that it can cause depression. I don't suffer from depression, but it does run in my family. Is this something I should be concerned about?
Benlysta. I'll have to preface this with, whenever a physician talks about something, they're supposed to give out disclaimers. And I'll say a disclaimer of mine is that I'm on the speaking bureau for GSK, which is Benlysta. But I'll also add this, is that I stopped giving talks for pharmaceutical companies many years ago because I hated the horrible slides the lawyers would make us use, because I like to give good talks and they would have these horrible talks. Well, I'm such a strong believer in Benlysta. I do speak for them, and it is an amazing medication. And so first, let's talk about side effects and how side effects are reported in clinical trials. The way a clinical trial is performed is you give the medication to a bunch of people, give placebo to a bunch of people. Then every time they come into the clinic, you give them this big long list of questions saying, have you had a cold during the past month? Have you had a headache in the past month? Have you had any joint pain in the past month? And then you check off yes if you had them. Well, you can kind of understand that over time, you might have all these potential side effects that are not truly side effects. The FDA has the pharmaceutical company report these things as potential side effects, but they're not always definite side effects. And so does depression happen with Benlysta or not? We actually truly do not know for sure. I think that it's a possibility though, because this is the week of the American College of Rheumatology meeting, and all the doctors are going over all the research from the last year. And just this morning, a study came out where they looked at, it's the largest study that ever looked at Benlysta, and the chief of the Lupus Center at Duke, she's the one who presented it. And there was over 4,000 patients, over 2,000 were on Benlysta, the other over 2,000 were on placebo or a standard of care therapy. And out of all those patients, there was only 15 patients in the Benlysta group who had a severe depression episode. There was 5 who had it in the placebo group. So even out of 2,000 patients who were taking Benlysta, there was literally just 10 who had a severe depression episode. And all 10 of them, by the way, had a history of psychiatric issues beforehand. So the person who asked this question, if you've never had a problem with depression, even if we think that Benlysta might cause severe depression in some patients, it's minuscule, and it didn't even happen in patients who did not have a history of psychiatric issues. Another interesting thing is that that was in the Benlysta IV trials, by the way. Benlysta is either given through an IV and intravenous form or a self-injectable subcutaneous form. In the subcutaneous studies, they actually had 0 severe depression episodes in the clinical trials. But the difference is that they did not let people with severe psychiatric issues in that particular trial. But again, it tells us that people who don't have pre-existing severe psychiatric problems probably don't have anything to worry about. The other thing I'd like to point out, though, is how to look at clinical trials and side effects. And I just brought up the FDA-approved form for Benlysta on my other screen over here. And I'd just like to go over it with you real quick. A cool way to look at side effects is that you can almost bring up the clinical trials for any drug you want to, and you can look at it yourself and just look at the side effects yourself. And I'm just going to tell you what it says about Benlysta and the placebo. So for Benlysta in the phase 3 clinical trials, 6% of patients ended up having viral upper respiratory tract infections. And so they put that into the side effect, saying this is a potential side effect. But guess what? The placebo caused it in 7%. So placebo was 7%, but Benlysta was 6%. You do the math. Abdominal pain is a possibility. 2.6% of those on Benlysta had abdominal pain. 3.2% of placebo patients did. Nausea, 1.7% of patients on Benlysta. That's a possible side effect from Benlysta, but 3.6%, almost twice as much in the placebo group had caught it. So you have to be careful with how you interpret what's a potential side effect from drugs. Do your own investigation. Don't go by just what the pharmaceutical company gives you, because they have to give you what the FDA tells them to show you. It's like on those TV commercials, they can scare the crap out of you, but a lot of those things they mention are not true side effects at all. So I'm really glad we had that question, because it opens up a really important issue.
Great. Very interesting. Number 3 is I have SLE and RA with some joint damage. My pain is bearable without any need for pain medications. My inflammation is not terrible if I avoid my triggers, which are stress, UV lights, and lack of sleep. I take 1 200 milligram Plaquinol daily. Would I benefit from taking a DMARD such as Arriva, or would it be better to increase my Plaquinol to 2 daily?
Okay, so rheumatoid arthritis and lupus can definitely occur together. We call it rupus. The RH for rheumatoid, the upus for the lupus part. So rupus, and it does definitely occur. So first thing is, I'm so glad that she said I only have a little bit of inflammation. So many patients say that, and the problem is we want to get our diseases into remission, complete remission. A little bit of inflammation is bad, because a little bit of inflammation leads to ongoing organ damage over time. And that's what we want to stop. I mean, lupus patients are teens and 20s and 30-year-old women. I'm 59 years old and I have 0 organ damage. But lupus causes organ damage, and rheumatoid arthritis definitely causes organ damage in most people who have those disorders. So we want to get it completely into remission, because getting it into remission is the only way we can stop the organ damage. And the studies show that even small amount of inflammation is too much inflammation and causes organ damage. So you don't want to put up with that. You want to work with your doctor to figure out medicine combinations that gets it completely into remission. So don't be satisfied with a little bit of inflammation, first of all. So rheumatoid arthritis, most of the time Plaquinol or hydroxychloroquine is not enough. Almost everyone, or the vast majority of people, need something stronger. Methotrexate is usually the drug of choice, because 30% of our patients will go into remission, but then if that doesn't do it, we usually add a biologic to it. So I'll just say that's probably what is needed. And as far as hydroxychloroquine, is that the proper dose or not? The way that we dose it is based upon the American Academy of Ophthalmology recommendations, which, by the way, are horrible recommendations, but it's what we use because they wrote it down and they put it out in the medical literature. They're horrible recommendations because they really didn't do a very good study to look at the efficacy and safety based upon these dosing guidelines, but it's what we use. If you weigh 135 pounds or less, then the recommended dose is 200 milligrams. If you're between 135 and 175 pounds, the recommended dosage is 300 milligrams a day. If you're 175 or higher, then it's recommended to take 400 milligrams a day. But now we have a wonderful thing called Plaquinol drug levels, or hydroxychloroquine drug levels, and it's such an amazing advancement in the management of lupus patients. I absolutely do check these, and if you were my patient, I would check your hydroxychloroquine drug level, and if you were not at a therapeutic level, which is very common with just 200 milligrams, I would go up on the dosage of your hydroxychloroquine, and if that was above what the American Academy of Ophthalmology says, I would just send a note to your ophthalmologist saying, I'm watching her drug levels closely, and so don't worry at all about the dose. I'll worry about that myself. So that's my answer. You probably do need to be on a DMARD, and I would look at your drug levels to figure out your hydroxychloroquine dosage.
Okay, great. Number 4, I had a very high positive ANA titer at diagnosis. It was retested when I moved and began to see a new rheumatologist. When it was retested, it came back negative. When he saw my negative ANA, he questioned my diagnosis. Is this normal? Does my ANA need to be keep being tested after it was a very high positive?
Lupus secret number 2, always keep copies of all your medical records, every note, every laboratory result, because it can help prevent this exact problem. And so the good thing is that with your ANA becoming negative, we now know that means that typically happens in our lupus patients who get under very good control. And so that's actually a good sign in our patients with systemic lupus. About 20% to 30% of our systemic lupus patients will end up having their anti-nuclear antibody become negative. And we now know through studies, more recent studies, that our patients who end up with a negative ANA, that's a great sign, because those are patients who have a significantly lower risk of having flares of their lupus. In the first edition of my book, I said that we never have to repeat an ANA test once it's checked once and it's positive. But now it's going to be different in the second edition, because now we know that if we repeat it and it's negative, that's a good sign. That means you're under good control and you're at low risk of flaring, which is a great thing to hear. I've had this happen to a couple of my patients, so I'm sorry to hear that this happened to you as well. And it's definitely not your fault. Your doctor should have got those records also. But one of my patients, she had to move to Chicago. She forgot to get any of her records. She didn't ask me to send anything. Her doctor tested her. She was in remission. She was doing amazing. And her ANA test was negative. All her labs were negative. So he didn't believe it. He stopped her medicine. She ended up having her lupus attack her lungs again. And so that was a severe flare, unfortunately. And fortunately, she did move back to the area, and I got to see her again, and she did great after that. Another one of my patients was right here in Washington, D.C. She changed insurance companies and unfortunately had to switch to a different rheumatologist before that. And she went to a major medical center. She went to either George Washington or Georgetown, but she was in remission. ANA was negative. Everything was negative. And unfortunately, they stopped her medicines. She was not as fortunate. She ended up having a severe stroke through something called TTP, which is a really severe complication of lupus. She was a police officer, and it just totally devastated her. Fortunately, she came around, her treatment worked, her stroke symptoms gradually resolved over time, never completely went away, but I started seeing her again. She's now in remission. She's a police officer. She's actually ready to retire. This year, she actually ran a marathon. She's doing so much better. But if she could have had my records when she went over to see, the other rheumatologist, that could have completely prevented this, because they could have seen those positive lab tests initially. They would have saw my notes that said, yep, she has this malar rash and these these sores in her mouth, her white blood cell count is low, her ANA is positive, her anti-double stranded DNA is high. She definitely has lupus, and it could have prevented all of this. So please keep records of your own. And after every visit, when you see your rheumatologist, just ask the front desk to give you a copy of the last note and the last labs. That's the easiest way to do this. If you ask for all your records at once, you'll be charged some money to do it because it's so much work for the doctor's office. But if you do it little by little, it's a very easy thing to do free of charge.
Great. Okay, our next question is, what's your opinion of hormone replacement therapy for a 66-year-old woman with late onset at age 62 of SLE? She started taking HRT at the age of 48.
Okay, so hormone replacement therapy is, we typically give it to women after they go through menopause, primarily because of hot flashes. Hot flashes can just really be devastating to some women and really greatly interfere with the quality of life. And so taking hormone replacement therapy such as estrogen and progesterone can really be just life-changing for women after they go through menopause. During the first 5 to 10 years after menopause, it appears to be incredibly safe. In fact, there have been studies, the Women's Health Initiative was a study of over 27,000 women. It was a long study, and it showed that women in the age group of 50 to 60, that there was actually less mortality. There was less deaths in those who took hormone replacement therapy in addition to helping them with their hot flashes. So in that age group, it's good. Unfortunately, in the older patients, especially patients 65 years of age and older, there were significantly more cardiovascular events, heart attacks, strokes, and blood clots. And so most experts recommend not taking it if you're 65 years of age and older. Between 60 and 65, that's a kind of iffy in-between period of time. But it's great that you took it when you were 45, but now that you're 65, I would recommend stopping it. And if you're still having hot flashes, there are other potential therapies. For example, the antidepressants called SSRIs like Prozac and Paxil, they can actually be helpful. And there's also some other therapies like gabapentin that can help as well. Not as good as the hormones, but a lot safer.
Okay, that's great information. Is it safe to stay on Plaquinol for more than 10 years if you have no eye toxicity? What is the standard dose?
Okay, so now that I've been a rheumatologist specializing in lupus now for close to 30 years, so I have patients who have been on it for 30 years, and it's absolutely very safe in the vast majority of our patients. I already talked about the dosage and how we figured that out. There's the guidelines, and then using drug levels to help figure out the doses. That's how I would do it. But the vast majority of people will not get an eye problem. And for people who don't understand, in some people, hydroxychloroquine can deposit in the back of the eye called the retina. And the retina, just think of it as being like when you go to the movies and you see the movie on the screen, that's what the retina is like. It's basically like the screen for seeing the movie of everything in front of us. But in some people with hydroxychloroquine, it will damage that retina over time. But the good news is that the eye tests that we have today are so good that the eye doctor would pick up something way before a patient would notice it. Unfortunately, I know that there's people watching this seminar right now who unfortunately have had permanent eye damage from hydroxychloroquine, and it is most likely because you didn't get the right tests. And I know some of these people personally who didn't. But you want to be proactive in your healthcare and make sure you get the right tests. You want to have 2 tests every single year religiously. One is called an SDOCT, and I'll rattle these off, but if you just go to my Lupus Secrets on lupusencyclopedia.com, you'll easily find them. They're in the Lupus Secrets, actually. You want an SDOCT and also a visual field test called a visual field 10-2. The 10-2 is incredibly important because most ophthalmologists have a 24-2 machine, but they don't have the 10-2. Too many times I've had patients and seen patients who are not getting the right test done, and a 24-2 will miss this Plaquinol toxicity problem. So you want those 2 particular tests done religiously every year, and if you do, your eye doctor would pick it up way before you would ever notice anything. Also, the Plaquinol drug level is helpful. Dr. Michelle Petrie at Johns Hopkins just recently showed us that as long as the level stays below 1500, the chances for eye problems from hydroxychloroquine is very low. So if we stick to those three things, those 2 eye tests every year, plus make sure the drug level is okay, eye problems from Plaquinol should be incredibly rare. Another important thing for our Asian patients listening to me right now, you need 3 eye tests every year. And that's also in the Lupus Secrets. You do need that visual field 24-2 every year, along with the other 2 tests. And the reason for that is that about 50% of Asians will actually have Plaquinol affect the outside of the retina instead of the center part of the retina. And so the 10-2 will miss it in those patients. They need the 24-2. So if you're Asian, please get 3 eye tests every year. And I guarantee you, most eye doctors don't know that. In fact, I know they don't, because I've seen almost every Asian patient of mine where I've had to ask the eye doctor to do it myself.
Okay, good information for those out there. Here's another question. I have heard that more doctors are keeping their patients on a low maintenance dose of prednisone. I am nervous about staying on it long terms. What is your thoughts about this?
You're a wonderful patient. You're being proactive for your own health because you're nervous about staying on even low doses of prednisone. I hope that the trend is actually less doctors or less rheumatologists are keeping their patients on low dose prednisone. That's actually an old-fashioned, outdated way of thinking now. The generation before me definitely did that. They taught us actually in rheumatology fellowship that most lupus patients should stay on low dose prednisone. So there is a reason why your doctor thinks that. But now we know that even low dose prednisone is dangerous. Last year in the Lancet, which is a medical journal from England, in the November issue, they did this really nice study. They looked at over 9,000 lupus patients in the Pacific and Australia area. And then they asked the question, what about those patients who are in remission and taking prednisone? Do they get organ damage over time? And so that's what they looked at. They just looked at those patients in that group who were in complete remission, so their lupus was doing great, but they were still taking prednisone. And you might wonder, why would a patient still be taking prednisone if they're in remission? One thing is because of those doctors possibly thinking exactly what this person was asking them their question, but also this is a very common scenario. I have a patient on 4 milligrams of prednisone. I drop her down to 3 and she flares. And so I put her back to 4, and it seems like every time I go down that little tiny bit, she flares. So I end up having to keep her on 4 and try to figure out another way to control her. But that's the kind of patient they were looking at. What they showed is that those patients, even on low doses of prednisone who were in remission, had ongoing organ damage. Ongoing organ damage, and their average dose of prednisone, what would you guess it was? Molly, you have any guess?
3, 4?
Close, 2 milligrams a day.
Oh, wow.
2 milligrams a day on average, but they continued to have ongoing organ damage. We want to get to 0 milligrams of prednisone. And now the medicines are so good, like Benlysta, that most of our patients should be able, in my clinic, most of my patients are in remission. Most of my patients, or they have low disease activity, and most of them are not on prednisone anymore because we have so many good medicines these days. And I can catch which ones are not being good with their medicines by checking their drug levels.
It's a good test for them.
Yes, absolutely.
Okay, our next question is about Benlysta, actually. It's how long does it take for Benlysta to start working and showing improvement with pain and fatigue? On the flip side, how long does it take to stop working after it's discontinued?
Okay, very good. So even though I'm a big Benlysta proponent, by the way, because it is a great medicine, by the way, it's incredibly safe and it's incredibly effective. However, not everybody responds to it. So this is a very good question. And by the way, the people who respond, who are most likely to respond, those of you listening, is if you have a high anti-double stranded DNA level or low C3 or low C4 complement level, you have a great chance of responding. Those are my patients who almost always respond, especially where it's great for fatigue and joint pain. What are the two most horrible things of lupus? Fatigue and joint pain. So if you have those two things and have a high double-stranded DNA or low complements, Benlysta probably is a good choice for you. Anyways, it starts to work around 1 month is about the earliest anyone notices any difference. Most patients around 6 months is when they notice a difference, but it can take as long as a year in some patients. So I always tell patients, give it at least a full year. And then you want to keep track of your symptoms. It may not totally get rid of everything, but even if it improves those symptoms at the 1 year mark, you really should consider continuing it. And the reason for that is that the longer patients take it, the studies show that the less severe their flares get over time and the less often they occur. And that's exactly what I see in my own clinical practice. As far as how long it takes to wear off when you stop it, I don't really know the answer to that, because if someone's doing well on it, I'm not going to stop it. If I stop it, it's because either they don't tolerate it or it's just not working.
Okay. We have a couple questions who have come in from the Facebook Live chat so far. Let me start with this one. What can you substitute if you can no longer take Plaquinol?
Yeah, that's a good question. If it's the eye problem, unfortunately, nothing. We used to have a medicine called quinacrine, also called quinacrine, which I used a lot in my patients. It's an anti-malarial medicine that does not cause any eye problems whatsoever. But unfortunately, the manufacturer has not kept up with the strict FDA-approved requirements for producing the medicine. And so we've actually had a shortage of quinacrine now for about a year. And it's actually not a shortage, we just have zero quinacrine. And this is worldwide, by the way. From my understanding, the company who makes it is in Germany, I believe. So they're still not able to make quinacrine. I hope it comes around, because we absolutely do have patients who can't take Plaquinol or hydroxychloroquine because of the eye problem or other problems. At this point, I truly do think that Benlysta is the best medicine out there as far as safety and how good it works. And also another good thing about Benlysta, by the way, why I really love it, is they just came out with the 7-year data on the patients who've been taking it for more than 7 years. And there was markedly less organ damage over time in those patients who were on Benlysta compared to those who were taking standard of care. What they did is they compared the lupus patients of Dr. Murray Urowitz. He's a lupus expert in Toronto, great rheumatologist, lupus expert. His patients are on the best treatments possible. They compared his patients to those patients taking Benlysta. And the ones who were taking Benlysta along with their medicines, they had a 61% less chance of having ongoing organ damage each year that they took it compared to the patients who were taking the usual medicine. So Benlysta is a really good medicine. And today, that's what I would say is I would definitely try Benlysta.
Okay, well, I've been on Benlysta for 7 years, and I've had the privilege of being in remission for 3 of those years. So I can definitely recommend that as well.
And Molly, I have to say you look great. I saw you in 2014. I could tell that you weren't doing very well, and you just look amazing now. So congratulations. I'm so glad to hear that and see it.
Oh, thanks so much. I appreciate that. We've got a couple more questions, and then we'll finish up here. Hi, Dr. Thomas. What are complements, and what does it mean when they are low? How can we fix low complements?
Okay, that's a really good question. Complements are a protein that's produced by the immune system, and they're proteins that are absolutely essential. For example, if we get a bacteria into our body like Streptococcus pneumoniae, which is strep throat, it's the complements that are one of the first things that identify those bad bacteria, and these complement proteins attach to the bad bacteria, and then this helps to cause the white blood cells of the immune system to come and attack those bacteria. A problem with lupus is that in lupus, we call this the complement activation pathway. The complements get activated to attack these bacteria, but in lupus, most lupus patients also have a problem where the complement pathways get activated. And in that complement activation system, and just think of these complements, causing the white blood cells of the body to attack your own cells. Instead of bacteria, they're attacking your own body instead of the bacteria. And so what happens during this process is that C3 and C4 complement decrease because they end up getting used up in this complement activation process. And so one of the ways that we can look for lupus disease activity is by measuring C3 and C4 complements. And if they're real low, then that's a reliable way to see that lupus is active in our patients. However, there's a big problem with this, by the way. Most patients, their C3 and C4 are perfectly normal or they're high. And the reason for this is that we have great livers that produce C3 and C4. And when there's inflammation going on in the body, the liver starts to churn out a lot of C3 and C4. So a lot of times, or actually in most patients, they overtake that low C3 and C4 and they normalize it. And so in a lot of our lupus patients, they'll have a normal C3 and C4, even though they have incredibly active disease, and it's because the liver is making so much C3 and C4. But there's better blood tests out there now. And I know some of you have heard of it. There's a company called Epigenetics, which is a laboratory that makes a type of blood test that we can monitor lupus patients that measures something called CB caps. And CB caps is a type of complement that isn't interfered with by the liver making extra C3 and C4. So now I can actually monitor my lupus patients by measuring this new blood test that measures complements in a much better way that helps me monitor my lupus patients better. And I hope that more rheumatologists will start using these tests by Epigenetics because it's a better way to follow the complement immune system. Now, what can you do to normalize this complement activation problem is by doing everything on my Lupus Secrets handout. Avoiding the sun, taking your medicines regularly, taking your Plaquinol religiously, taking your vitamin D religiously. You have to control your lupus, and it has to be by taking your medicines, eating a good diet, getting enough sleep, exercising. There are a lot of things that are in your control to help out.
That's great. And our final question of the afternoon or evening, depending on where you are. Why do people of color, especially Blacks, suffer with lupus at higher rates?
And that is a sad thing. Definitely there's higher rates of lupus and more severe lupus in certain ethnicities than in other ethnicities. And it most likely does have to do with the genetic pool. People of African descent, they do have more genes that can cause lupus and that are more likely to cause lupus compared to Caucasians. It also occurs more commonly in Hispanics and Asians as well. And unfortunately, African Americans tend to get more severe disease. And just one example is that lupus nephritis, which is inflammation of the kidneys, where lupus attacks the kidneys. And before we had great treatments like we have today, was one of the major causes of death in our lupus patients. And most patients ended up going on dialysis and needing kidney transplants and things like that. But when you look at African Americans, they're much more likely to get lupus nephritis than Caucasians. Caucasians, it happens about 25 to 30% of the time. But in our patients of African ancestry, it's more around 50 to 60% of the time. If you're of Afro-Caribbean descent and you're female, it's about 78% likelihood, and it is because of that genetic pool that predisposes to that whole gene thing. I think that for the future, in order to find a cure for lupus or prevent people from getting it, we need to figure out how to prevent those genes from turning on. It's going to be a genetic type of therapy that's going to happen, but unfortunately, it is the genetic pool or genes that are in African Americans.
Okay. Well, that's our final question of the day. Thank you so much, Dr. Thomas, for answering all of our group's questions. We thoroughly enjoyed it, and we're so happy you were here.
You're welcome, and thanks so much for having me, Molly and Kelly. Everybody have a nice weekend.
Thank you. Before we log off real quickly, we wanted to do a quick giveaway. We had promised to give away something, and so we have a quick trivia question before we log off. And this question was taken from Dr. Thomas's best-selling book, The Lupus Encyclopedia, which is available on Amazon and also on his website, lupusencyclopedia.com. And whoever submits their answer first will receive a copy of My Special Butterfly, which is a book to help children understand a loved one's life with lupus. So here is your question. Please listen and get your answer in as soon as you can. There is evidence that lupus is an ancient disease. The oldest evidence of lupus was from a mummy of a 14-year-old girl who died in AD 890. In which country did she reside? Was it A, Spain, B, Peru, or C, Egypt? Spain, Peru, or Egypt? Now we will wait to see who responds correctly to that answer, that question, and we will send you a copy of My Special Butterfly. So I just want to thank again Molly and Dr. Thomas. Unfortunately, we've run out of time. I had planned to give a short presentation, but don't worry, we'll be doing a part 2 this week, which will include it in its entirety. So thank you and congratulations to the winner. We'll be checking your responses after we close this Facebook session. Deepest thanks to Dr. Thomas and Molly McCabe. And stay tuned for more patient-driven programs coming your way from More Than Lupus. Hope all of you have a great weekend. Thank you.
An hour went by quickly.
Sure did. Let me just close this up. I will